Welcome to this episode, where we're diving deep into the 2018 Diabetes Canada Clinical Practice Guidelines chapter on type 1 diabetes in children and adolescents. It's a comprehensive and nuanced look at managing T1D in the pediatric population, which, as we know, presents unique challenges compared to adults.
Absolutely. It's a complex landscape, right? From diagnosis to long-term management, the pediatric population demands specialized care, not just medically, but developmentally and psychosocially as well. So we're going to unpack the key recommendations and insights from this guideline, focusing on what really matters for clinicians and researchers working with kids and teens.
Let's start with diagnosis and initial management. The guidelines emphasize that any suspicion of diabetes in a child should lead to immediate confirmation and treatment initiation to reduce the risk of diabetic ketoacidosis, or DKA, and DKA remains a leading cause of morbidity and mortality in this group.
Right, and what's critical here is that pediatric DKA management differs significantly from adults because of the increased risk of cerebral edema. That's a serious, sometimes fatal complication that's much more common in kids.
Exactly, so pediatric-specific protocols are essential. They stress cautious fluid replacement over about 48 hours, avoiding rapid administration of hypotonic fluids, and delaying insulin infusion until at least an hour after starting fluids. Also, insulin boluses are contraindicated because they may increase cerebral edema risk.
And children presenting with new-onset diabetes and DKA usually require hospitalization for stabilization and insulin initiation. But interestingly, for medically stable new-onset cases without DKA, outpatient education has been shown to be effective and more cost-efficient, provided there's access to an interprofessional pediatric diabetes healthcare team.
That team is key: pediatric endocrinologists or pediatricians with diabetes expertise, dietitians, diabetes nurse educators, social workers, and mental health professionals. The education they provide covers insulin action and dosing, blood glucose and ketone monitoring, sick day management, nutrition, physical activity, and hypoglycemia prevention.
And anticipatory guidance is crucial, especially during developmental transitions like starting school or adolescence. Providers should proactively discuss psychosocial issues, substance use, driving, and even career planning with families and patients.
That's a lot to cover, but it's necessary given the complexity of managing T1D in children.
Moving on to glycemic targets, the guideline recommends aiming for an A1C of 7.5% or less in children and adolescents under 18. Preprandial plasma glucose targets are between 4 and 8 mmol per liter, with 2-hour postprandial targets of 5 to 10 mmol per liter.
But these targets aren't one-size-fits-all. Especially in young children under 6, there's a need for caution, because severe hypoglycemia can have lasting cognitive effects, like impairments in memory and learning.
Yes, and on the flip side, chronic hyperglycemia and glycemic variability have been linked to structural changes in white matter and poorer cognitive performance. So it's really a balancing act. Tight control reduces long-term complications, but increases hypoglycemia risk, which itself can harm neurodevelopment.
The so-called honeymoon period, after diagnosis, lasting up to 2 years, is a window where insulin requirements are lower and glycemic control is easier. It's an opportunity to optimize management before more intensive therapy is needed.
And clinical judgment is paramount in setting and adjusting targets, especially for kids with hypoglycemia unawareness or previous severe hypoglycemia episodes.
Speaking of therapy, insulin remains the cornerstone of management. Basal bolus regimens using long-acting basal insulin analogs combined with rapid-acting bolus analogs are the standard approach.
Continuous subcutaneous insulin infusion, or CSII insulin pump therapy, is safe and effective at any age. It may offer slight improvements in glycemic control and reduce hypoglycemia compared to multiple daily injections.
The STAR3 study is a good example, showing sensor-augmented pump therapy outperformed multiple daily injections in children with poorly controlled diabetes.
But it's worth noting that large population-based studies haven't consistently shown improved A1C with basal bolus, or CSII, compared to older NPH-based regimens. So individualization is key, considering age, diabetes duration, family lifestyle, school support, socioeconomic factors, and preferences.
And insulin therapy should be reassessed regularly to ensure it meets glycemic targets, minimizes hypoglycemia, and allows flexibility in daily life.
On the monitoring front, self-monitoring of blood glucose frequency correlates strongly with better glycemic control. Continuous glucose monitoring, or CGM, adds the advantage of detecting asymptomatic hyperglycemia.
Some pediatric studies show CGM improves glycemic control and reduces hypoglycemia. But randomized trials have mixed results in children and adolescents, partly because sensor adherence tends to be lower than in adults.
Advanced pump features like low glucose suspend algorithms have been shown to reduce nocturnal hypoglycemia, which is a big deal for safety and quality of life.
And then there's the closed-loop pancreas system, the so-called artificial or bionic pancreas, which integrates insulin pumps, glucose sensors, and control algorithms to automate insulin delivery.
Early studies are promising, showing reductions in hypoglycemia and improved time in target glucose range. But most data are short-term and from varied clinical settings. Larger randomized trials in youth are underway to establish safety and efficacy.
It's exciting technology, but we have to be cautious and evidence-based.
Nutrition is another cornerstone. All children with T1D should receive counseling from dietitians experienced in pediatric diabetes.
The guidelines recommend following Canada's Food Guide, a balanced diet with adequate fiber and limited fat. Carbohydrate counting is widely used to match insulin dosing to intake, though fat and protein also influence postprandial glucose.
There's no strong evidence favoring one nutrition therapy over another for glycemic control, so individualization is essential. Plans should be regularly evaluated to ensure normal growth and development without compromising control.
Screening for eating disorders is critical, especially in adolescents, given the higher prevalence and association with poor metabolic control.
Hypoglycemia remains a major barrier to achieving glycemic targets. Severe hypoglycemia is particularly concerning in young children due to potential cognitive effects.
Treatment of mild hypoglycemia involves age-appropriate carbohydrate intake, for example, glucose tablets or juice in specific amounts depending on age.
Mini-dose glucagon, dosed at 10 micrograms per year of age with minimum and maximum limits, is effective for home management of mild or impending hypoglycemia when oral intake isn't possible.
Severe hypoglycemia in unconscious children requires intravenous dextrose or glucagon administration, with dosing adjusted by age.
Frequent CGM use may reduce hypoglycemia episodes, but no insulin regimen has proven superior for resolving non-severe hypoglycemia. Treatment must be individualized.
Now, for children with persistently poor metabolic control, say A1C over 10%, the guidelines recommend comprehensive multidisciplinary assessment.
Factors contributing to poor control include depression, eating disorders, socioeconomic challenges, family conflict, and low support.
Psychosocial interventions targeting emotional and family dynamics can modestly improve glycemic control and reduce hospital admissions.
Screening for psychological disorders should be routine, given the high prevalence of diabetes distress, depression, anxiety, and eating disorders.
Parental psychological distress significantly impacts child diabetes management and outcomes, so family-centered care is essential.
Physical activity is often overlooked but important. Inactivity is common in children with diabetes, and interventions to increase activity can reduce A1C by about 0.5%.
The recommendation is regular physical activity at least 3 times a week for 60 minutes or more each time.
Turning to DKA, it occurs in roughly 28 to 40% of children at diabetes onset and remains a frequent complication in established diabetes.
It's the leading cause of morbidity and mortality in pediatric diabetes. Younger children under 3 and those from low prevalence areas are at higher risk of severe DKA at diagnosis.
Public awareness campaigns have effectively reduced DKA incidence at diagnosis by educating parents, caregivers, and healthcare providers about early symptoms.
In established diabetes, DKA often results from insulin omission or poor sick day management.
Risk factors include poor metabolic control, previous DKA episodes, adolescence, female sex, CSIIUs, ethnic minority status, psychiatric disorders, and difficult family circumstances.
Prevention strategies include education, behavioral interventions, family support, and 24-hour telephone or telemedicine access.
Pediatric DKA management requires careful fluid replacement over 48 hours, avoiding rapid hypotonic fluids, and delayed insulin infusion start.
Insulin boluses are contraindicated due to increased cerebral edema risk.
Cerebral edema complicates about 0.5 to 1% of pediatric DKA cases, with high morbidity and mortality.
Risk factors for cerebral edema include young age under 5, new onset diabetes, severe acidosis, high serum urea, low PCO2, rapid hypotonic fluid administration, insulin bolus, early insulin infusion, failure of serum sodium to rise, and bicarbonate use.
Treatment of cerebral edema includes mannitol or hypertonic saline, though evidence is insufficient to favor one over the other.
On vaccination, influenza vaccination is recommended to prevent illness that could complicate diabetes management, even though there's no strong evidence of increased influenza morbidity in children with T1D.
Smoking prevention and cessation counseling are essential because smoking increases cardiovascular risk and worsens metabolic control in adolescent smokers.
Adolescents with diabetes have similar or higher rates of alcohol and illicit drug use compared to peers, so regular counseling is advised.
Sexual health and contraception counseling are critical for adolescent females to prevent unplanned pregnancies, which carry higher risks in poorly controlled diabetes.
Various contraceptive methods, oral contraceptives, intrauterine devices, barrier methods, are safe and effective in this population.
Psychological disorders are prevalent in children and adolescents with T1D, increasing during adolescence and emerging adulthood.
Diabetes distress, depression, anxiety, eating disorders, and externalizing disorders negatively impact diabetes management and outcomes.
Eating disorders, including insulin omission for weight control, occur in about 10% of adolescent females with T1D, double the rate of peers without diabetes.
Eating disorders are linked to poor metabolic control and accelerated microvascular complications.
Screening for psychological and eating disorders should be routine, with referral to mental health specialists as needed.
Psychosocial interventions improve mental health, quality of life, treatment adherence, and glycemic control.
On comorbid autoimmune conditions, autoimmune thyroid disease affects 15 to 30% of children with T1D, with risk related to thyroid antibody status at diagnosis.
Hypothyroidism is more common in girls at puberty. Screening with TSH and thyroid peroxidase antibodies is recommended at diagnosis and every 2 years thereafter.
More frequent screening is indicated if antibodies are positive or symptoms develop.
Primary adrenal insufficiency is rare, but should be considered in cases of unexplained recurrent hypoglycemia and decreasing insulin needs.
Celiac disease occurs in 4 to 9% of children with T1D, often asymptomatic.
Screening is recommended for symptomatic children, but universal screening and treatment of asymptomatic celiac disease remain controversial.
Gluten-free diet improves symptoms and prevents long-term complications in classic or atypical celiac disease.
Screening for diabetes complications is age-dependent. Nephropathy screening with first morning urine albumin to creatinine ratio should start at age 12 with more than 5 years of diabetes duration.
Persistent albuminuria requires confirmation and treatment per adult guidelines, typically with ACE inhibitors.
Retinopathy screening begins at age 15 with more than 5 years duration. If control is good and no retinopathy is present, screening intervals may extend to 2 years.
Neuropathy screening is recommended annually after 5 years duration in adolescents with poor control, though diagnostic tools have limitations.
Dyslipidemia screening starts at age 12 or earlier if risk factors exist. Statin therapy is effective, but LDL cutoffs for treatment initiation in children are not well defined.
Hypertension screening should occur at least twice yearly, with treatment following general pediatric guidelines.
Finally, transition to adult care is a vulnerable period. Emerging adulthood between 18 and 25 years is marked by high risk of loss to follow-up, deteriorating glycemic control, and increased adverse outcomes including DKA.
Between 1/4 and 2/3 of young adults experience gaps in care during transition.
Structured transition programs starting in early adolescence, around age 12, with education, readiness assessments, transition coordinators, and support improve outcomes.
Emphasizing autonomy and self-management skills is critical to successful transition.
So to sum up, managing pediatric type 1 diabetes requires a multidisciplinary approach that addresses medical, psychosocial, and developmental needs.
Glycemic targets must balance tight control with hypoglycemia risk, especially in young children.
Insulin regimens and glucose monitoring technologies should be individualized and regularly reassessed.
Prevention and careful management of DKA and cerebral edema are paramount.
Psychosocial screening and intervention are as important as metabolic control.
Comorbid autoimmune diseases and diabetes complications require systematic screening and management.
And transition to adult care is a critical phase needing structured support.
It's a lot to take in, but these guidelines provide a solid framework for optimizing care in this complex population.
Definitely. Thanks for exploring this with me.
Thanks. Until next time.